Um, I also want to really hope that you've been enjoying the workshop from the past 2 days. Um, so I would like you to really share your excitement in the chat, or you can also use the emojis to share how excited you are for this final wrap-up session of this workshop. So if you're happy to share your excitement as I welcome you on board again this evening, can you just type something you have learned in the past 2 days in the chat, and you can also share it through emojis, whichever is convenient for you. Um, please feel free to share your excitement. What has stood out for you through this workshop? What have you learned that you didn't know before now? What are the exceptional moments that got you really excited, that got you super interested in M&E for digital health and all of that? So I'll just give like a minute or two for you to share your excitement. Just type in the chat or use emojis if that works better for you. Would be happy to see your reactions. Great. I can see one from Kabir. Nice to have that. A thumbs up. Oh, wow. Yes, let's keep them coming. Great, great, great. I'm really glad to share your excitement. I know that you probably have learned a lot in the course of this workshop, and many thanks to our facilitators. Thank you for dishing out those wealth of knowledge. We are really grateful for your presence and your commitment. All right, great, great. I saw the emojis and they are super amazing. If you still want to type anything in the chat, please go ahead. The chat is open for you to share your excitement. What stood out for you in the course of this workshop? What new concept did you learn? Yeah, just from this morning session, I learned a lot myself, the various impact evaluation methods stood out for me, and the deep explanations that the facilitators gave were really amazing for me. Oh, great. It's been an insightful workshop. Yeah, thank you for sharing. Yeah, I can see someone who has the same excitement as me. Impact evaluation methods and evaluation models. Great. Let's keep them coming. Let's keep them coming. So this evening, based on where I am, if it is morning or afternoon at your end, it's still fine. Just to give you heads up into what we have in stock, of course, from the program schedule, you know that we are wrapping up um, on this session. This is the final session for the workshop. And we are super excited to welcome you once again. And just to walk you through the agenda for this final wrap-up session, we'll be starting with a fireside chat. Our panelists are super ready to share experiences, to share knowledge with us. So it's not just going to be about learning the concept, learning the tools, learning how to use them, learning how to conduct evaluation, learning how to analyze, collect and analyze data. But there'll be life experiences that will be shared. How do you move forward with all of this knowledge and skill that you have acquired in the course of this workshop? So that's the major essence of this fireside chat. And because our facilitators have wealth of experience. They'll be happy to share them with us. Then we'll be moving on to case study presentation. I remember in the morning session, announcement was made um, along that line for those who would be excited to share their presentation and then receive feedback from the panelists. Then we'll be having a quiz that covers every aspect of the workshop from the past 2 days up until the session we had this morning. And then finally, we'll be launching the M&E in Digital Health Advanced Fellowship. And as we get close to that particular part of the program, you'd be gaining more insight into it. So once again, warm welcome to you all. Thank you for sending your standout moments in the chat. I can see a lot of them, and I'm really super excited that this workshop has made so much impact in your lives and in your career. Great. Now, I would like to welcome our panelist in person of Justus Ashaba, and some others will be joining us as we go ahead with the presentation. But for us to save time, we would be starting with Justus. I assure you that even from his profile, you know that he has lots of experiences in digital health, M&E, and he is so generous to share those experiences with us. So Justus, if you're on the call, I want to formally welcome you to this fireside chat, and we are super excited to have you share your wealth of experience with us. Can you just say hello to the audience?
Yeah, thank you very much, the moderators, and thank you all participants for connecting again. Yeah, we look forward to sharing more uh, in a two-way kind of learning
Thank
structure.
you so much. Thank you so much, Justus. It's so nice to hear you again this evening, and I'm sure that you have a lot in stock for us in this chat. Let me say quickly for the audience that you would have opportunity to ask questions as the chat goes on. So you can use the chat box to type in your questions so that when we ask a few questions from my end, we would also be happy to take your questions so that some of your thoughts or unclear areas as you went through this workshop would be clarified and your questions will also be answered. So please feel free to type in your questions in the chat. If they are not already covered in the questions that would be asked from my end, then we would be happy to take them up. Thank you so much as you do that. So right straight into um, the chat. So Justus, welcome again. And the first question is here. And this is the question. Can you share a real world example of where M&E made a significant difference in the success or failure of a digital health project, particularly in demonstrating value for sustainability and securing long-term funding or government adoption? So if you're happy, Justus, I'll go over the question again. Can you share a real-world experience of where M&E made a significant difference in the success or failure of a digital health project, and with a particular focus in demonstrating value for sustainability and securing long-term funding or government adoption? I hope you got that. If you're happy to go, please, you can share your experience on that. Thank you.
Yeah, thank you very much. I've picked that very well. So maybe what I will share, very many really programs and applications I've participated in and I've guided. But what I can pick for our clear understanding, I'll pick an example that is way back in, I think, 2019, before even the COVID pandemic, because that was a time when I think digital health was working, but in a natural kind of way, we had not yet got some kind of factor that would maybe push many partners, many people to appreciate use of digital tools. So those days, everyone was comfortable. We are working in our normal environments. And in such a time, there's a health partner within Uganda who I think this model is common in many countries where Ministry of Health, yes, works, supports health facilities, but then they are what we call implementation partners who manage various projects, funding to support Ministry of Health in some of the work that is done in health facilities and in communities. So in that kind of arrangement, an implementing partner was given an assignment to implement a project for 3 years. And in these 3 years, the project was covering almost the whole country, but each region was having some different implementation arrangements. And one of the regions, there was an intervention to develop and implement a digital health application that would improve case outcomes for tuberculosis and HIV. So I think that region was the one identified as having a problem where people are not responding to the service cascade for HIV and tuberculosis uh, uh, services. So in this case, that region which contained maybe like 5 districts, uh, there was an implementation that would have that digital health implementation installed and used by health facilities in that region so that that application would support registration of art clinic patients, tuberculosis patients who are getting treatment. And then, of course, such an application would improve on their records at the facilities. It would also help to remind them of their time to come back to hospitals and take their, their treatments. So you know those are conditions where people really take medicine for months and months. For example, tuberculosis, a patient may go for maybe 6 months plus, and HIV almost it's a routine practice for someone to really be taking their treatment. But in this case, it means facilities, of course, always need to monitor those patients and give them more guidance, more care, and help them take their medicine well, have their follow-up visits regularly. But patients sometimes are unable to really follow such schedules because of various factors. But then here, this tool came in to empower the facilities to track the patient statuses very well, and then also remind the patients to come back to facilities for any due services. So this was conceptualized in this way. It was implemented in that time. I think, of course, the health facilities didn't have the IT infrastructure, so an investment was done to make sure the ICT infrastructure required was put at the health facilities in 5 or 6 districts. The people, all the stakeholders were trained, consultants were hired to develop that application and put it in place and run it. So what happened is they really programmed that, they implemented and moved on as usual. And of course, as they moved on, they used to do the monitoring to check, are we developing the applications well? Are we engaging everyone? Are we training all the intended users? All was done well. And from the monitoring, all the results were showing that things are okay. And every time stakeholders would have quarterly review meetings, things would look positive. And the project came to an end after 2 years, and with other 6 month additional, where that application was used continuously, though not in an intensive phase of the project mode. So I can say all that work was done for like 2.5 years. And it came at a point now where there was need to do an evaluation at the end of 2.5 years to check what was the result out of this implementation. And that time I was called in to support that evaluation. In fact, to lead that evaluation as the lead M&E specialist. And my role, of course, there, as we've gone through all these aspects, my role was to go back and read the project design, look at the expected results the stakeholders had planned to achieve. Then I compared all the monitoring reports that have been generated during the project time. So I had to read all that so that I'm able to design the evaluation in terms of which questions to be asked, what data variables should I collect. Of course, I went through all that with other team members guiding every work, and we reached a point where we are ready to go to the field for data collection, because most of the data was with the health facilities and the beneficiaries. So part of the data was within the digital health system, which we got access to. So when we reached in the region, we had to go to the authority that was hosting the database of that application at the regional implementing partner. We had to access records at the facility. Some of them were paper-based, but most of the information was within the database. We also had to access lists of those beneficiaries. We did some kind of random selection of the beneficiaries who we would reach out. We reached out to them with interviews and surveys. So we did all the work like we've really described. So a time came for data analysis, so I had to really do much work to do the analysis of the quantitative data we collected. I also had interviews and focus group discussions that we had recorded. So we had to get audio data, transcribe it, apply all the qualitative data analysis methods, and got some insights. So in the analysis, we combined quantitative data aspects and the qualitative data analysis results, and we compiled the report while using those data analytics from the collected data to make sure that the report flows very well and communicates. And what came out of that evaluation was a bit surprising to the stakeholders. Remember, I've mentioned all the process during the monitoring activities, everything was positive and all looking well. But when it came to the evaluation, surely, in summary, what I can say is that the evaluation indicated that really the digital solution that was put in place did not add much as maybe stakeholders were earlier claiming. So, of course, we had baseline data. The situation before that digital implementation was put in place. We had regional trends of how patients were performing on those services. Then later, we also compared with the situation during, uh, during the project. We also compared with the situation, those other 6 months that followed after, when the project reduced effort. So all that gave us an insight, and we came to a conclusion that surely the application had not contributed to the results we needed or that were expected. And of course, stakeholders welcomed that message. And within the report, as the evaluation team, we had looked at what had contributed maybe to, what could have contributed to such a trend, what are some of the recommendations within that stakeholders can take on as they implement that project or that activity within the next period in case they consider extending it. So what we realized is what most of the monitoring reports were giving, the monitoring reports were more a bit of course as monitoring is, they are just uh, excited about the outputs. We've given tablets to how many facilities, we have trained health workers, the system is in place, we have installed everything required. So of course that would become positive. But then the actual, remember now here, the actual change would come from is the system really communicating to the patients. So what happened is that during implementation, of course, that functionality was provided, and somehow I think in those initial days, they saw the system communicating, but then it's like for a longer period, the system then didn't continue communicating as people expected. So somehow during the evaluation, we learned that to some extent, there was not intentional follow-up now to check on those uh, results beyond the functionality of the system. Because if a system functions today, and then you see it communicating with patients, it can make lists of patients that are due tomorrow. So you getting that result today be should not tell you that it's obvious the system will continue doing it even in the next weeks, the next months. But what we realized is that like stakeholders became comfortable and did not continue the monitoring and being intentional to check if those results from the system were continuous and consistent. So at the end of the period, we realized not many people really came to hospital because they were reminded by the system. And then, of course, at the facility, some tasks were still in paper-based because maybe the system was not able to cater for those. So in summary, we realized we didn't get really positive results in terms of contribution and attribution from that digital health application. So after looking at such results and of course the descriptions of what was happening in the field and the recommendations, the stakeholders now understood the situation. And for the next round of funding, they had to concentrate on other factors that were not paid attention to within the initial implementation. So the partner that was handling the digital health application in terms of technical support, initially they had hired just one consultant who was like the software developer, who was like the systems support. He was the M&E person. So someone was overloaded, and I believe they could not pay attention to all the details of what digital health M&E is. So they would just implement what was comfortable to them. So in the next implementation, it was clear that more people needed to be assigned and given a responsibility to really monitor the whole cascade of the system's functionality, and somehow also separate roles between IT, monitoring and evaluation, because clearly from this discussion, we should be able to see that these are different roles. You cannot say someone who is developing the software will have the same skills of evaluating how the software is working, will have the same skills of presenting M&E reports to stakeholders. So when this was taken up and improved a bit, the structure of the program was improved a bit. In the next periods, it was really implemented better. And as a result, so that was 2019. So some work continued throughout the COVID time. And immediately after looking at the problems that affected the initial implementation, and now stakeholders were comfortable to see what can be improved, that structure or that digital health implementation was taken up at the national level starting 2021, and it was rolled out on a national level where they had to develop a national level case-based surveillance system for tuberculosis, and experience from the previous smaller scopes implementation helped a lot because then here stakeholders knew where problems could come from. They knew what would cause much success, and things now looked better in the next implementation. And that system has been working now since 2021 up to now, and we see great success because people learned from the evaluation that was done initially, and different problems could not be repeated. So I can summarize it that way up to here. Yeah, over to you.
Thank you very much. Thank you so much, Justus, for that amazing and comprehensive response. You provided such a comprehensive case study for the application of M&E in digital health um, project, basically. And audience, if you ask me, there were so many salient lessons to learn from that response that Justus just gave. And just a few, one of them was that monitoring and evaluation are not the same. They are related, but they are not the same. Remember, he said that monitoring gave positive answers, but when they came to evaluation, they found out that that intervention had not made any impact. And then secondly, I love the fact that the recommendations that were made led to improvement. And of course, the project or intervention is now working well right now. And that helps us to also remember that monitoring and evaluation, the essence of monitoring and evaluation is for improvement, while research basically seeks to prove, monitoring and evaluation seeks to improve. Thank you so much for that. And I also want to acknowledge that Khalifa also sent something in the chat, sharing an experience that he also had in line with the question. I'll be moving on to the second and the final question so we can move straight into the case study presentation. So Justus, we want to look into the future right now because I'm sure that a lot of people on this call have heard about the fact that AI is here to stay, you know, applications of AI in M&E, looking at the present state of things. Um, can you take us into the future in projection? Looking 5 to 10 years ahead. I know that's about a lot of time, but let's just project to help those who are just coming into the field, or even those who have been practicing M&E for, a bit of time. How do you see the digital health M&E evolving with AI, predictive analytics, and big data? These are common words that we hear every now and then. How should the next generation of professionals prepare, you know, based on this buzz about AI, about predictive analytics, about big data, and everything seems to sound confusing. Somehow there seems to be like an overload of knowledge, of skill, and so on. In the midst of these words that we hear, AI, predictive analytics, big data, can you take us into the future, you know, about 5 to 10 years from now? How do you think the next generation of M&E professionals can prepare to adapt, you know, adapt into this new trend that we are getting into? Thank you, Justus.
Thank you very much. Yes, so looking at the digital era that we are in and various changes, how they come in the technologies we use, clearly we can say, okay, in 10 years to come, maybe if we are to get some kind of insight, we can also first look behind 10 years back, what was the situation, how were people doing things, and what kind of change has happened. So we say a lot really has changed when you go back to 2015 up to now 2025. So I can see a lot of things have changed in how ministries of health were working, how data was being utilized. So Now, that pace of change can tell me that, okay, even in the next 10 years to come for sure, we expect a lot of improvements. And of course, technologies are changing now and then, but what we can really appreciate at least is that they are all changing for good and for better. So every time technologies come, they come to really solve current problems and they really help us to be better. But then, as we mentioned, it may not be obvious that everyone will be better just automatically. So it is important that we really develop our skills. So even in this situation where we talk of AI as a solution to everything, maybe as a solution to using data, you realize AI may not complete. In fact, it does not work out things without our guidance. There has to be someone to guide it, what to do to apply it, because it's also technology, so that you are able to leverage on it. So what I can imagine, yes, many improvements will have happened and they will help us to go away from the difficulties we are facing now because we realize we understood we have limitations, challenges that are affecting us or that we may face as we do this work. So those challenges, what I can project is that some of them, in fact, most of them may not be really challenges. Because when you talk of challenges like skills, we believe with better technology now people are able to learn faster. So if you go back 10 years, I don't think we would really have such a session that would be massively where information would reach very many people and many people would have that capacity and capability to connect and learn such a new topic. But then you see with technology, such is possible. So even in the next time to come, now that we are able to learn very fast, we have the technology that can allow us to learn very fast. So it means we'll get better skills and overcome many challenges that we currently face. And maybe another emphasis is that we have to have the right skills. If we talk of technologies, AI and others, so it means us who are currently doing that work, we always need to be adaptable to change with the situation. If a new technology comes in, it's presenting some advantages, we need to be the first people to learn how to utilize that technology, how to use it to solve the current challenges. So like, for example, when you talk of AI now, it's not that AI right now is helping everyone. So some people are still behind. Some people don't know how to really utilize it in terms of information search or even data analytics. So it means one challenge we have if we are to benefit from such changes, we have to really adapt and always learn from the new changes that happen so that we can apply it better, we can benefit better. And in all this, I think other important challenges that it poses to us is that we have to be detail oriented. We do not just take things on their surface. Uh, as we do our work hearing that AI is a solution and then you just also believe and think AI is a solution. So we have to be detail oriented, pay attention, ask those logical questions. For example, if they tell you AI will help you to reduce malaria situation to improve the malaria situation in your country, and they are putting a lot of pressure to implement AI and maybe you don't even know where to start from. So don't go by such pressures and obvious thoughts that AI will solve your problem. So be logical in your thinking, really pay attention to all the details. That's when we can benefit from such technologies and even those that will come in the future. Yeah, I can share that for now in the interest of time. Over.
Thank you so
Thank
much.
you.
Okay, over to you, Shola. I thought you dropped off.
Yes, I actually dropped off a bit, but thankfully, my connection was restored. Thank you for coming in. Okay, thank you so much, Justus, for sharing that great insight. So for the audience, you've learned from that answer, I believe. The fact that AI, big data are here to stay does not mean that we should throw everything to them. We can actually leverage them for brainstorming and other aspects, but not completely giving up everything that we need to do professionally to AI, because they also have their limitations. Thank you very much, Justus, for sharing those insights. I want to acknowledge Belite in the chat. Thank you for sharing these also. And if you need more clarification, we would be happy to also take them. So I was expecting one or two people to share whatever questions they might have in the chat, but I can see that there's none for now. But notwithstanding, you can type in the chat, but at this point, we'd be happy to move on to the case study presentation. I know that a number of participants have indicated interest in presenting their case study answers or responses. And yes, thankfully, Justus is also available to listen to them and provide valuable feedback that would help in improving and doing it better. So thank you so much for indicating interest. So without wasting time, I'd like to acknowledge that Khalifa, Abba Matthew, and Gabasa have indicated interest, and we'll be going in that order into the presentation.
Yeah,
So
so maybe before we start the presentations,
yes,
our colleague here, Gabriel, has shared a thought here. Maybe we can also look at it quickly and see how to progress. So what he mentions, of course, is that we are talking about impact when we are evaluating these applications or digital health, and we say we want to measure their impact based on the health program's impact, of course. And then for him, he thinks, okay, if we do it that way, we may now, it may be a disadvantage because we are judging the digital health against what would be the expected impact from the health programs. And of course, it's obvious because the health programs may fail to achieve the, the, the impact expected because of very many other factors, maybe beyond that digital health application that you are implementing. So that's his thought, that if we judge the digital health implementations and expect them to really give us the impact we need from health programs, it may be a disadvantage. So maybe, Gabriel, is that what you are communicating? If you can confirm. Yeah, so he says yes. So what I would imagine, yes, of course, what you mentioned is a limitation, but clearly, when you look at it logically, a health program is working to achieve any impact that it's intended. Let it be the quality of life, let it be the morbidity, the mortality. Those are really what the health program expects. And of course, at the design of the program, remember what we said is that these digital health interventions should be enablers. They should come to help us solve some challenges that are limiting our health programs from meeting their outcomes and impact. So logically, when you bring in that digital health intervention, remember it should be an enabler. Its whole goal should be to help that program achieve its results. So you realize it's also logical and somehow it makes sense to judge that digital health against the outcomes and impact of that health program. Because in actual sense, that's why it is coming in to improve the program. So if the program really does not improve in its impact, then it means for sure the digital health application then has not done what it was intended. Yeah, but all these again depend on the scope and the design of your intervention at start. Remember, a health program is a wide program with various scopes. So obviously, if it has maybe an impact that is to be caused by maybe 5 outcomes, and then your digital health application is contributing to maybe 2 outcomes out of the 5 outcomes of the program, then you are able to judge that digital health implication out of those outcomes it's contributing to, or the results that it has attributed that it has caused. So you may now not judge the digital health application on the impact, but at least the outcomes for sure. It's also a good stage where you can base and say this digital health implementation was supposed to help us on 2 outcomes, maybe 2 out of the 5 outcomes of the whole program, and you should surely see that outcome coming out clearly. And there you are still right to judge that digital health against those program outcomes. So if you see that maybe the impact may not be appropriate to be measured on the digital health, then at least outcomes should be the right result areas to focus on and assess your digital health. But what remains clear and key practice is that you should not work around some outputs from digital health. When you achieve them, you celebrate. No. Digital health should be an enabler for our health goals to be achieved. Over. We can move on to the presentations.
All right. Thank you so much, Justus, for providing that clarification. And I really do hope that that has helped Gabriel in your line of thought. So the basic thing is that
Okay, can I share my screen from my side? Just I update some slide.
okay, no worries. So thank you so much. We'll be moving straight into the case study presentation, and I'll be calling on Khalifa Mahmood for his presentation. Afterwards, Justus will be providing feedback on this presentation. Over to you, Khalifa.
Can you see my screen?
Yes, it's visible.
Please, you have just 3 minutes. Thank you.
Can you see my screen?
Yes, we can see it. Please go ahead.
Hello. Okay, thank you for giving me the chance to present my case study presentation. Yeah, I already selected case study 3, digital health and innovation. The title is Scaling a Mobile Health App for Maternal Health in Uganda. So, as usual in MND, we follow this path. First, in planning, we do baseline assessments. Then we will follow the same process. Just to save my time, I will progress to the questions. So the first question is about developing a logical model or a result framework for mama care application. So our input will be funding, resources. It may be from donors or partners or from governments, or it may be from both sides. Also, since we are working on health, we have to have a partnership with Ministry of Health, mobile platforms, how we can communicate this up with the clients, health contacts, depending on the health sector in Uganda, we have to have NC schedules, danger signs. So this should be defined and used as an input during our project. Also, if there is a trained health workers and the community health volunteers or family health team, in our case, we say family health team or health extension workers. So we will use them as an input. Mobile phones and telecom partnership, we have to have a partnership with telecom companies. MND stuff in the data system. It may be the HIS2 or another dashboard that have this data. We will perform activities or processes such as registering pregnant women via health facilities or family health team or volunteer health teams. We have to send automated SMS reminders and message through the app, operate emergency hotline referral linkage. So this is a very important activities, train health workers on mama care use. So since it is a new project and we have to, on the pilot area, we have to train the health workers on the applications. Also, we have to integrate the app data with our national DHIS2. Also, we have to conduct routine monitoring and the periodic evaluations since it is very important to follow the progress. The output will be number of women enrolled into the project, a number of SMS reminders sent to the pregnant women, number of hotline calls handled, number of facility using mama care during the project times, number of health workers trained during our process, dashboard report generated after we perform the activities. There should be a report that we generate. This should be an output. As an outcome, we expect that increased timely ANC attendance, ANC1, ANC2, up to ANC4. It can be short to medium term outcome will be increased timely ANC attendance, increased skill birth attendance. There should be increased number of pregnant women that will be attend the birth at health facilities, improved maternal knowledge of danger signs. So we are alarming them on danger signs. So our mothers should have to get a knowledge on danger sign, improve the referral response during the ANC time. Sorry. The second question is suggest at least three smart indicators at output, at outcome, and impact levels. So we can use different indicators at the three levels. For output level, for example, percentage of registered pregnant women receiving at least 90, we can say 90 or 95% of scheduled SMS reminders during pregnancy, number of active mama care users, per district per month, proportion of enrolled facilities submitting mama care data to the DHIS2 monthly. For outcome level, percentage of mama care users completing at least 4 NC visits before delivery, percentage of mama care users delivering with a skilled birth attendant, percentage of users who can correctly identify at least 3 pregnancy danger signs. For impact level, maternal mortality ratio among mama care users compared to non-users, rate of pregnant-related complications. This can be eclampsia or hemorrhage among mama care users. Are you with me?
Yes, we are with you. You should be rounding off
Okay.
by now.
The third question is about digital dashboard, strength real time. How it can help us to, for example, it enables us to use real time monitoring, track registration, NC attendance, missed visit instantly, early warning signals. We can give a woman, we can flag a woman missing NC appointment or report danger signs, data integration, align mama care indicator with national DHS2 reporting, and enable to remove parallel systems. Geographical equity analysis, we can visualize coverage gaps across district and hard to reach areas. Decision support, enable district health officers and the Ministry of Health to act quickly. For donors, dashboard demonstrate accountability, transparency, and scalability. The fourth question is what methods could use to capture qualitative evidences? So we can use a mixed method for evaluation, user-centered methods, focus group discussion, in-depth interview with first-time users and dropouts, mobile-based feedback surveys. Health system perspective, we can use key informative interview with midwives, volunteer health teams, district health officers, facility level observation on workflow integration. For equity and trust, case study of rural, low literacy, marginalized women, most significant change, stories on how mama care affected care-seeking behavior, trust and accountability. We can also perform trust and accountability assessment. The final question is how can monitoring and evaluation finding can be framed to influence policymakers and the donors for scale up? Finally, our finding can be used for policymakers to align result. We have to align result with national priorities. For every country have their national priorities, we have to align with that show system benefits. We have to show them how the system will benefit as a country, reduced missed visit, better referrals, strong DHS to data. We have to emphasize on government ownership and integration, not a standalone application. So for policymakers, we can emphasizes on it. For donors, present clear evidence pathways, application, behavioral change, health outcomes, highlight cost effectiveness of the application. We have to showcase equity gains and reach to rural undeserved population. We have to show that use dashboard, the maps, and the short success stories alongside the statistics during the project for the donors. To use my time, I will finish it in here. Thank you very much for your attention.
All right, great. Thank you so much, Khalifa, for that presentation. Justus, I would want you to please let us take all the presentations before you give feedback to them so that we can have everything collectively. Thank you so much for understanding. Thank you so much, Khalifa. Please, I'll be calling on the next presenter, but I would want to encourage you to please, if it is possible that you don't have to read through every word in the slide, that would be helpful to us. You can just summarize the main points so that we can stay within the time limit. Thank you so much. So I'll be calling on Abba Matthew for his presentation. Thank you, Abba. You have the floor. Hello,
Okay, thank
Abba.
you.
Are you on the call?
Yes, can you hear me?
Yes, please go ahead.
All right, good evening. I'm doing a case study 5, that's policy and community engagement, titled Strengthening Routine Immunization Through Community Health Workers in Kenya. So we can just go over the table of contents. There's no need. The goal of this framework is to generate a reliable, timely, and community-owned evidence that improve routine immunization coverage across the selected community in Kenya. Sorry for the mix-up on the font. So the MIE framework for the immunization project, we looked at the input, that is the number one input is the number of communities selected, choose trend in immunization tracking and reporting, digital reporting tools with paper backup, supportive supervision from a state health team, and number of community engagement meeting and a caregiver dialogue session held, and basic logistics support like airtime, transport refund. The output is a monthly digital immunizations report submitted by the CHOOS, that is community health workers, mother receiving a reminder on missed immunization cases identified and followed up through SMS on a weekly or monthly basis, community feedback on the immunization services documented digitally through case tracking or through WhatsApp platform or Google form, and routine review of meeting held within the health authorities across maybe through stakeholder, community women, and women of reproductive age, and they choose using digital system like Google Drive, Google Sheet, Kobo Collect, or WhatsApp, as the case may be. The outcome is improved data quality, timely, and the completeness of the community immunization data, increased caregiver trust immunization services and choose role through the reminders, and better alignment between community level data and facility record, increased immunization attendance and services delivery, and improve the use of immunization record data for decision making. That is the community intervention base. The impact is reduced missed routine immunization among children under 1 year through the SMS reminder by their mother, and strong community participation, immunization planning, and monitoring through community stakeholder engagement, identifying the inputs, and the improved evidence use of immunization decision making at a subnational and national level. Average reporting time for health facilities will be increased, and the number of decisions made based on immunization records data. Our assumption show that health facility remain functional while this activity is going on. A mobile network available. Supervisor provide regular support through stipend and transport refund. Community leader support engagement through stakeholder, and authority remain respective to community data. Second question is data quality indicator for the community health worker reporting. The completeness will be number of submitted reports within with all the required data field, and the percentage of expected monthly report received. The timeliness is number of community health worker reports submitted on or before the agreed timeline, and the average days of between data collection and submission. The accuracy is a percentage of agreement between community health worker record at the facility immunization registered during spot check, and 50 discrepancies identified during routine data verification exercises, and completeness is the number submitted reports. Yeah, and then the percentage of expected monthly reports received. The integrity community perspective, that is the trust and acceptance, will be short caregiver feedback survey and administered quarterly at the community level through the SMS receive and the feedback, and the focus group discussion with caregiver, community leaders, and women group, community health worker receive log documentation, and the community concern, misconception, and feedback through the community stakeholder community validation meeting to discuss findings, inputs, and agreed on activities. Key trust indicator will be mother respond to SMS reminder and follow up on appointment that will be sent on monthly or weekly basis. Caregiver understanding of why immunization data is collected, and community health worker consistently enter accurate immunization data and perceive usefulness of the community health worker follow-up visits. The low-cost digital innovation to improve the community health worker performance will be SMS reminder to mother, automated confirmation message to acknowledge report submission digitally, simple SMS alerts to flag missed immunization cases for mother, and the quarterly feedback to summarize feedback with choose SMS and WhatsApp, and a community health worker peer learning group using existing message platform to improve services, and the use of MIE finding to influence national immunization policy will be demonstrating the added value of community health worker and improving data completeness and providing evidence of community trust as a critical factor in immunization uptake through community engagement and stakeholder engagement, and information guideline on integrating community generated data into routine immunization, and support policy dialogue at the national and subnational level, and strengthen advocacy through the SMS and community engagement. Conclusion, evidence will be presented in a simple decision-focused format tailored to policymaker, highlighting practical lessons that could be adopted and scaled up on the national level. Thank you.
All right, thank you so much, Matthew, for that amazing presentation. Would be getting feedback from Justus once we have the final presentation. At this point, I'm happy to call on Mustafa for his presentation. Mustafa, if you're on the call, please, you have the floor. Thank you. Hello, Mustafa, are you with us? Hello.
I think we should just take the Comments from just us.
Yeah, I see
All right.
Mustafa is not on, so we can skip this. So thank you very much, members. I will first go to Khalifa's presentation. Yeah, thank you very much. Let me check here the topic. Khalifa was more taking us through it was an ANC program where we were trying to help the mothers, the pregnant mothers, really go through the service, and at the end of it all, we expect improved outcomes out of their journey of pregnancy. Yeah, so the concepts were clear, and most of the aspects really are okay. Maybe two comments I have on his presentation. When it came to outputs, in his logical model, okay, yeah, this one exactly. So when you look at the language used in these sectors, inputs, activities, outputs, outcomes. So when you talk of a results framework, here you're talking of results. And in this case, we expect to see statements that really tell a result. So they should be more of result statements. For example, yeah, for inputs and activities, they are okay because activities, these are action. The verb here should be action, that will do this, do this. There has to be registration. So register pregnant women is fine. So the language here is okay, conduct something. But when it comes to outputs, outcomes, and impact, we need to talk of result statements. So when you look at outcomes, when you talk of increased timely ANC attendance, at least you see that's a result, something that you can now say this was achieved. When you look at the impact, yes, it's also in a good language, reduced maternal mortality. But the issue here, what I wanted to comment is on outputs. So you somehow deferred, the language now changed to indicators, and that takes away the consistency. So even outputs here, you should have continued that language of the result statements. For example, instead of saying number of women enrolled, so you just look at what do you expect when you conduct these trainings and you enroll people, what do you expect out of the activities? So maybe here you would expect pregnant women enrolled on the application. You'd expect SMS reminders being sent. So again, we need to have the outputs aligned here to the language of the result statements, not indicators in this box. So of course, indicators are also utilized on another level where you will go now changing each result statement to the indicators, but then that will be in another kind of, another step of now looking at the indicators for these results. But when we are on this logical results framework, we should mind about the language and be sure that we are using result statements. Then another area in the indicators language, when we go to his next slide where he mentioned about indicators, I think it's the next. Yeah. So these indicators before, of course, the indicators are aligning or they are being derived from the expected results in terms of the output, outcome, and impact. So when you look at aspects to do with the output, remember outputs are when you do an activity and something is coming out immediately out of that activity. So when you talk of register a percentage of registered pregnant women receiving at least at least 95% of the scheduled SMSs, in many cases, really, at the output level, we wouldn't expect uh, aspects to do with changes and ratios and comparisons of Okay, let me maybe read continue. So you're talking about receiving SMS reminders. Maybe that's okay. But when you talk of proportion of enrolled health facilities submitting, so this submission, it's okay. I see maybe it's an output because you're talking about submission of data. But in many cases, you need to pay attention and be careful that you don't mix the changes, the expected changes, and you bring them into the outputs. For example, at the outcome level, he mentions percentage of users completing at least 4 ANC visits. So maybe, yeah, that's a change after giving SMSs and they respond. So you see that trend changing, that's okay. So what I wanted to pay attention is that at the output level, you be sure that you don't mix changes in practice and behavior into this, and you bring them into the outputs. Yeah, what had caught my attention are words like percentage of, proportion of, but I believe maybe when you structure it well and you remain at your output, that can be okay. But in many cases, the mistakes that people do is now bring in, for example, percentage of women who are now uh, getting better outcome, and then you bring it to the output. There has to be a difference, and make sure that you don't mix the results. Okay, quickly when we go to
Sorry,
Matthew's
sorry.
presentation.
Is there a problem with the indicators that I have to update?
No, I was to checking and being sure that you are not mixing them, but they seem to be fine.
Yeah, on
Because
the output, it is about the number of data sent, the number of pregnant women registered.
yes, they are
There
they
is
are
no
okay.
any statement indicator about the change due to the project implementation.
I Yeah, there is no change. I had noted that.
Exactly.
I wanted to be sure that we reread them and be
Okay,
sure
okay,
you're not bringing a change in the output. So
okay,
it's
okay,
okay. We've noted it's not a change.
okay.
Yeah. So for Matthew,
Thank you.
I had yeah, the presentation was also good. Most of the concepts are really straightforward, but 2 points also that I wanted to comment about within the result statements. Of course, when you talk about the results like this, the results, previous slide, previous, the one with the framework. So the result statements are okay, no problem. But what I wanted to point out is a result, for example, uh, this outcome of better alignment between community level data and facility records. So when you hear about such a result, better alignment, so it means if you are to measure better alignment, there has to be some indicators you really use to, to measure what alignment is. So most of the time, when you read the result, sometimes it gives you clearly what you are going to measure. But sometimes the results are not straightforward and you may not convert directly from a result to an indicator. So you have to pay attention. So I'm using this as an example to show you that sometimes conversion from results to indicators can be complex and you really need to pay attention. Because in simple terms, normally what we can do is when you look at the result, for example, like monthly digital immunization report submitted. So obviously the indicator would be the number of uh, reports submitted. So you see that it's kind of a bit a direct translation. When you talk of increased caregiver trust, of course, now that is not straightforward. Like you will go and measure trust. There is nothing like a trust measure that you have straightforward. So you have to convert this result into measurable indicators. And our colleague here, Matthew, really tried his best and did it well. Because, for example, when you talk of better alignment of reports, when he came to the indicators, he had to now bring in something that you are able to measure. For example, he talked of what I had picked is, he talked of, for example, you look at the data agreement. If a report is coming from the facility and a report is coming from the community, how much proportion of those reports are talking of the same thing. So the result there is being broken down into something that you can measure. So things to do with better alignment between community and facility records, improved trust. They are not things you just measure the way they are, but you have to bring in important, you have to bring in relevant indicators for you to be able to measure such indirect results. Okay, so for example, the issue of trust, where I was mentioning that you may not go to the records and measure trust there, but is trying to say, okay, if I look at the beneficiaries who received an SMS and then responded to that SMS, if the SMS was telling someone to go to the facility or take their treatment, medicine, and they did it, so Matthew is trying to tell us that if someone receives an SMS and they respond to what the SMS is telling them, they have trusted the health system and they are now okay to take the instructions. So meaning they are trusting that whole process. So Matthew is telling us that once someone gets an SMS and then he responds or does the action that the SMS is telling them to do, it's what we will take as an indicator or a measure for trust, which is okay. So I just wanted to use it as an example to show you that some results, you have to look for appropriate indicators that are not just copy and paste from the result statements. And then when it came to the somewhere, either on the results framework, I think there were more outcomes in the place of impact. Yeah, so instead of impact, the results that were showed as impact, they seem to be more of outcomes because they are like immediate changes that come. So not sure if we are able to go back and clarify on it. I think it's one of those first two slides, especially around, okay, previous. Yes, here. When it came to impact, okay, so when we look at reduced missed immunization, when you look at stronger community participation, and then you look at improved evidence, okay, improved evidence in use of immunization to make decisions. So these sound more of immediate results. For example, I would say when people receive the SMSs, of course, they will go to the facility, and what comes immediately for sure is that the missed visits will reduce. So when you say, when you talk of reduced missed visits in terms of impact, it may not fit in well. That sounds like an immediate outcome, an immediate result, which is outcome. But then when you have consistency in people attending the NC visits, it's when we expect now the impact to happen. So somehow you may need to review that part and be sure that you are not mentioning outcomes in the place of impact. Yeah, I can stop here for now and we check if there are any questions or if we are moving on to the next part.
Thank you so much, Justus, for all of those insightful feedback. And I want to hope that not just Matthew and Khalifa alone, but everyone on the call has learned one or two lessons from those feedback and even the presentation themselves. And we will all get better for it. Thank you so much again, Justus, for coming in with those feedback. at this point, we are set to move into the quiz. And I want to invite Vivian to take us through the quiz. Thank you, Vivian.
All right, thank you so much, Shola and Justus, and to all the presenters. So right now, this is the final quiz for the workshop. It entails all the sessions so far from this morning till the past 2 days. So please scan the QR code on the screen. I think it's the same code we've been using, so please do that and let's kick off. I'd like to see yours join. Please, even if your name is on the screen, you need to still scan the QR code again and put in the code. So if you see your name on the screen, please, you still need to come back. This was for I think yesterday. You still need to rejoin. If not, you won't be able to access the updated questions. Let's kindly join. We're still waiting for more people. If you're on YouTube, you can also participate. Doesn't mean just scan the QR code on the screen, go to slido.com and put in the link so that you can participate. All right, so I'm starting now. If you have not joined, please do it so that you can be a part of it. And we're happy to provide a space to the winner in our upcoming fellowship. If the winner is interested, we're happy to provide you a free slot to be a part of the fellowship as a reward for winning the overall quiz. Okay, so let's take it serious. Let's start now. All right, we've started. The first question is from the morning session. What evaluation design? Sorry about that. What evaluation design is the strongest for measuring impact? So please, you can put in your answer. You have less than 10 seconds to do that. And I hope you can see my screen and you're following along. Okay. All right, so that's the end. Let's see the answer. Yeah, majority of us got that. So to the next, okay, we have Ashnefi, sorry, on the leaderboard. The next question now is, what is the limitation of impact evaluation in digital health? What is the limitation of impact evaluation in digital health? I think this was also from the morning session. Time up. Okay. All right, I can see that most of us are getting the answer. We still have Ashnafi on the leaderboard leading. So the third question, so we have 15. So please, this might take a few minutes to get through. Each question is 20 seconds. So just give us a few minutes to finish the quiz and we go to the final announcement as we close this workshop. What is the main purpose of a monitoring and evaluation report in digital health? Okay. These are really simple questions that I believe if you've been a part of the workshop, you should actually get. Wow, Ashnafi is still on the board. Now to the fourth question. What is participatory monitoring and evaluation in digital health? What is participatory? I think this was one thing Andrew talked about in the morning. He mentioned a few types of impact evaluation, different ways you can do it. Okay, so you can see most of us are getting it. All right, some new names are coming up to the leaderboard. Now, Why is attribution important in the impact evaluation of digital health interventions across Africa? Why is attribution important? So let's see who's going to get this. Okay, so time up. All right, nice one. I hope people on YouTube are participating as well. We want to ensure everybody has a chance to be a part of it. So please let's check on our YouTube participants that they are also on the quiz. Okay, so next question now. We're on the sixth question. We're halfway done. Which statement best distinguishes monitoring from evaluation? If you remember, we had worked on this quiz. I think that was the first, on the first day. On the first day. So you should get it. Okay, so let's see the answer. C is continuous and evaluation assesses achievement of objectives and impacts. Let's see the leaderboard now. Wow, Ashinafi is having a streak. Okay, so let's go to the next one. Which of the following is an output rather than an outcome? I think this was what Justus has been emphasizing all along. We need to differentiate between output and outcome and also impact because they are quite different. Okay, so let's see. All right, let's see who we. Okay, Ashinafi is still on the roll. I can't wait to know who that person is because I don't know if it's a nickname or if that's your real name. So descriptive analytics primarily does what? I think that's from Faith session on data. All right, time up. Okay. Summarizes historical data. Okay. Next, we have which data source is primarily qualitative and suited for smaller samples. If you've been on the call since day one, this should be very cheap. So this is the cheapest question here. This is the cheapest question here. Everybody should get this. All right. Okay, key format interviews. Okay, Belit is now he's now contending with Ashinafi. Let's see if he's able to move up. 10th question is reduced reporting delays is classified as what? I think if you are listening to just those explanations thus far, even for this last presentation, this was one example he had mentioned. So, all right, time up. Okay, so let's see. Outcome. Wow, Belit. Belit is now on top. Let's see if Ashnafi can come back up. So to the 11th question, which of the following is a deliverable in a digital health project? Better disease surveillance, trade health workers, improved data completeness, report generated electronically. So which of these is a deliverable in a digital health project? Okay, time up. All right, so answer is in. Let's see. All right, Belit is maintaining his position now. Now we have just three more questions to go. This is the third to the last. In digital health M&E, evaluation assesses all of the following except okay. right. Yeah, we are all correct. 95% of us got that. Okay, Belit has maintained this position. I hope it's not that Ashnafi dropped off the call or something. Well, let's see. We have just 2 more questions to go. Which of the following is not a key component of monitoring? Which of these is not a key component of monitoring? So just give us a few more minutes and we are wrapping up now. All right. Cost effectiveness compared to non-digital alternatives. Let's see. And wow, Belit and AJ. Okay, so let's go to the next question, which is the second to the last one for this workshop. What is the primary definition of a monitoring and evaluation framework? What is the primary definition? What is the primary definition? All right. I guess everybody should actually get this. Okay. And the last question of this workshop: which statement best distinguishes monitoring from evaluation? I think this is a repetition. So bonus, bonus to everyone. Bonus to everybody. Nobody should miss this. Nobody. Wow, we still have some people who missed it. Okay, so the answer remains the same. So congratulations to Belit. If you're on the call, please unmute your mic. Let's hear from you. Is Belit on the call? If I don't know if I'm pronouncing the name properly.
I think you pronounced correctly. My name is Bellet Tamtam. I'm Ethiopian. So I'm currently working as individual consultant after working for more than 50 years in HIS and MND.
Congratulations
Thank
to
you.
you. Thank you. Thank you so much. And you've won yourself a free, fully funded position in our advanced fellowship. So please, we will be in touch later in the month in February to get all your details to onboard you to the fellowship. So well done for the great work. So right about now, we'll just take a few announcements. Please, the link to the submission form for your case study will be sent immediately after this workshop. Please fill the form and upload your case study either as a PDF or as a PowerPoint or as a Word document. Please upload it to the form. Do not send it to our email. What we requested for the email was those who wants to present on this call. But as your final criteria, or one of the criteria to get your certificate, is to submit the case study. So use the form. Shola, please let me post the form on the chat. Use the Google form to submit your case study and also give us feedback on the workshop experience thus far. Thank you so much for doing that. But we'll also send the link to you through the email, but it's also going to be posted on the chat. Emmanuel, any of the team member, please kindly post the link on the chat. You have till Wednesday to submit that form. Once it's Wednesday, 11:59 p.m. West African time, that form is going to close. And once it's closed, we will not open it again. And we're going to work with only those who have submitted the form. So just know that there are 3 things for you to get your certificate. One is the pre-assessment form, the earlier one that was sent before the workshop started. 2 is you working on your case study and submitting it along with the post survey. So those are the 3 criteria to get your certificate, and you will get your certificate 2 weeks after the workshop so that we also can do our own analysis and ensure everybody getting the certificate has met up with the criteria. So in 2 weeks' time, please watch out for an email with your certificate. But please ensure if you don't get your certificate, just know it's either you did not fill the pre-survey form or you did not fill the post-survey form with your case study submitted. It could be either of those. So if you don't get it in 2 weeks, just know you didn't meet up with that criteria. But we hope everybody on this call had met up with the criteria. So thank you so much. Check your folder, the same link we've sent to you. The case studies are there. All the presentations of the facilitators are also there. And if you missed any session, kindly just go back to our YouTube channel to rewatch every single session of this workshop. And now to our announcement. We are really, really excited to share with you that by April, we will be starting the Advanced M&E in Digital Health Fellowship. What you've seen in 3 days is just the tip of the iceberg. We did not really go in depth, right? And some of the feedback, we've done this 3 days workshop for 6 cohorts, and the response we've gotten is we want more time, right? 3 days is not enough, and obviously it's not enough to really go deep dive into M&E in digital health, touch on the AI, predictive analytics, how do you integrate with electronic health records in terms of data system and collection. So we have designed this advanced M&E in digital health fellowship for everybody who is interested to go deeper into this area. So you'll be getting certification after it as well. You'd also be working on a more robust capstone project. So this case study is just for you to practicalize the few things you've learned in 3 days. But for the capstone for the fellowship, is going to be a longer one. It's 8 weeks. So that's about 3 months or 2 months and a half. So there's enough time to walk you through how to use Power BI, how to use all this analysis and visualization dashboard, GIS for health mapping. So the curriculum is more rich. We have 8 weeks to go through everything. You'll be mentored, you'll be paired with mentors. And we're not just, we are bringing more professionals on board. We are bringing colleagues from international organizations, WHO, Africa CDC. If you've seen our previous cohort, you see some experts that have spoken previously from UNICEF, WHO, GIZ, who were once facilitators on our 3 days workshop. So we are doing this for 8 weeks. And if you're interested, you can fill the wait list. So there's a wait list form that will also be shared in the comments at about now, and also via your email. So please fill the waitlist form to express your interest. It is not free, it's paid. Okay, so I believe it's worth your investment. And this is just one of the many certification program we are running this year. If you've been following us, you've seen that we've started the AI in healthcare certification program, which has been fully booked. So we've gotten over 50 professionals who are already on that certification program. So this is the second one we are launching this year, and we believe it's going to be impactful to every single person. Yeah, so we look forward to welcoming you to the fellowship, and we have just I think we have just 20 slots for this fellowship, so it's not a lot of space. So the earlier, the better. Once we get to 20 people, we are going to close out the registration. So let me know if you have any preliminary question for this, and I would answer. And that's the opportunity you have as being part of this, our cohort. And lastly, we're going to add all of you to our alumni page. So as I've said, we've done 6 cohorts of this 3 days workshop. So there are people who have done, who are in cohort 1, cohort 2. So all of them are on a WhatsApp page where we continually engage them. We've shared so many job opportunities on that page. Our mentors are also on that page, Justus and Drew. They're also on the WhatsApp alumni page where we continually engage with people who have gone through this 3 days workshop like yourself. So we will send you the WhatsApp link. You join and meet other people who have gone through this program so that we can continue to network and provide you continuous support in your professional journey. So, any questions before we close? Thank you all. This has been amazing. This has been great. All links, all slides, everything, you would have access to it. Just watch out for the final email from us on this workshop. We would add the waitlist form to the fellowship. We will add the case study form, submission form, and every other information we have been sharing. So thank you, thank you, thank you, thank you. Please do tell your friends, your colleagues that this is happening. You are the first to know about it. We've not published this online at all. So that's the leverage you have. So if you're interested, do fill the waitlist form and we're happy to welcome you. Thank you and see you in the fellowship, because that will be our next point of engagement. All right, do enjoy the rest of your week, of your weekend, and keep being the change agent in digital health on the continent, leveraging monitoring and evaluation frameworks to build evidence-based innovations and tools. So see you all. You can connect with us on LinkedIn, and we'll connect right back. You can share your experience, encourage others to be a part of the fellowship. You can connect with Justus, with Andrew, all our partners. We're also saying thank you so much to all our YouTube participants. Thank you. And we're sorry we couldn't bring you into Zoom because of the technical issues we faced. So thank you all for being a part of this. And we would see you, if possible, in the fellowship. Bye.
Yeah, thank you, everyone. We keep in touch.
Thank you, Justus.